you asked the question like, are they fluid tolerant? Can you talk a little bit
Mm,
more about how you would use Doppler to help you assess that in some cases around it?
definitely. I think fluid tolerance is one of the really important emerging concepts in acute care medicine. And the idea is that every treatment we do has a risk and a benefit. The benefit of giving somebody IV fluids, for example, is that we can increase their cardiac output. And by increasing their cardiac output and their stroke volume, we increase their perfusion and things get better. But like any
Hmm.
treatment, there's a potential risk. And the risk of IV fluids is really multifactorial. You can cause congestive organ injury, you can cause pulmonary edema, you can cause tissue edema, which can lead to kind of this microcirculatory dysfunction. You can cause endothelial dysfunction from over aggressive fluid resuscitation, actually like shredding the glycochelates in the vessels. There's a lot of potential harms. And we just need a concept to describe those potential harms, and that's fluid tolerance. And it's not just one thing. How I think about fluid tolerance is there's kind of a few different domains. The first is the acute illness that somebody is facing right now might make them more or less fluid tolerant. So, for example, if you have a patient that comes in with acute decompensated heart failure, they're not fluid tolerant. We would never even think about giving those patients fluid to try to improve their organ dysfunction because they're in pulmonary edema and acute overloaded heart failure. There's other more subtle conditions, however, like pancreatitis, for example. People with acute pancreatitis, they might respond well to fluid in the short term, but in the long term are actually not very fluid tolerant because they third space a lot of that fluid. And that third space fluid leads to ARDS. It can lead to abdominal compartment syndrome and other complications. In these situations, I think about giving fluids kind of like tapping a credit card.
Hmm.
You're out at the bar with friends, and you know what? You order a round of drinks for some friends, and then you have to go to pay. So you tap your credit card that night, and everything's all good because you're going to pay it off in the morning.
Right.
But the next night you go out again, and then you go out again, and before you realize you have a drinking problem, you keep going out time and time and time and time again, and you keep tapping your credit card. Eventually, that bill is going to have to be paid, otherwise, it's going to accumulate interest. Giving IV fluid boluses are a little bit like tapping your credit card. They definitely work in the short term to restore kind of forward flow, but you have to pay the price by mobilizing that fluid down the road. And you don't want to essentially have your credit card debt or your fluid debt build up so much that you actually get organ dysfunction as a result of it.
That's great. Excellent. Yep.
So with fluid tolerance, acute illness is kind of the first thing I think about. Then I think about chronic comorbidities. So we intuitively know that patients that have EFs of 5 to 10% or severe pulmonary hypertension are going to be much more. We're going to be much more cautious with IV fluids because they're more likely to be harmed by it. And then finally, I consider things like congestion, and that could be left-sided congestion or right-sided congestion. So a patient with pulmonary edema is going to be less likely to be fluid tolerant. A patient with severe venous congestion and RV dysfunction is going to be less likely to be fluid tolerant because as we give them fluids, there's a chance that this worsens their congestive organ injury. And so integrating those three components is kind of how I approach fluid tolerance for patients when I'm trying to weigh the risks of potentially giving a fluid
Yeah, and like
bolus.
back to your initial point, it's like the pancreatitis example, they might not be fluid tolerant and they might not be overtly volume overloaded. And then, don't have that venous congestion yet, maybe. And then you also mentioned like you have somebody with a low stroke volume and you're kind of weighing to get fluids versus vasopressors and kind of how can better understanding Dopplers help you with that?
Yeah. And I mean, I have to say, this is one of the hardest questions that still remains in acute care resuscitation. When do you switch over from giving somebody fluid resuscitation into vasopressors? I think it's pretty clear in 2025 that empiric amounts, like give 30 mils per kilo to everyone, make no sense. Nothing in medicine is a fixed dose,
Hmm.
right? You always have to tailor it to your patient in front of you. But the question, and a very important question comes, well, how do you decide what dose do you give? And so to me, my assessment of whether or not I should go into fluids or vasopressor starts with the microcirculation. Do they have surrogates of hypoperfusion, cap refill, elevated lactate, oliguria, some sort of marker that this patient's perfusion isn't adequate? Because often actually we get called for these patients after 4 liters, but then you look at them, you're like, actually your lactate's cleared, you're peeing. Let's not give you fluids or vasopressors right now. Like you're just doing okay. But let's say the patient is hypoperfused, they're hypotensive. The purpose of giving a fluid bolus is to increase something called the mean systemic filling pressure. The mean systemic filling pressure is if right now I have a cardiac arrest on this podcast, nobody does CPR on me, but a research assistant comes by and they put in an art line into me and they wait 20 minutes and they check the blood pressure and after I've died for 20 minutes. This is really morbid. But when they check that blood pressure, it's not zero because there's still pressure in my blood vessels. It's all equilibrated because there's no
Mhm.
flow, but there's a pressure. And the pressure is represented by two things: the tone of my vessels, the kind of elastins, but also how much fluid is in there. Think about a water balloon, for example. The pressure inside the water balloon is not zero. And the pressure inside the water balloon depends by what material the water balloon is made out of. Is it really like a kind of compliant water balloon? And how much water do you put in? And the more water you put in, the higher the pressure is. So the main systemic filling pressure is actually the main driver of venous return and cardiac output in our body. And it's the difference between the mean systemic filling pressure and your right atrial pressure. And so when you give somebody a fluid bolus, we give it with the hope of increasing our mean systemic filling pressure to drive more venous return. And it works for that because when you give somebody fluid bolus, it increases the volume inside the vessels. That causes a higher pressure and increases venous return. But it turns out that that's not the only way to increase your mean systemic filling pressure because there's the other component, the compliance or the elastance of the vessel. And if you give somebody vasopressors, you can also squeeze the venous system and increase that mean systemic filling pressure and drive more venous return. And so whenever I think about giving a fluid bolus, I always ask myself, and I have a bit of a luxury being in the ICU where I don't have to kind of factor about resource utilization and transfer to kind of higher level beds. But I always ask myself, if this patient's hypoperfused, they have low stroke volume, they're acting hypovolemic, is the treatment for this patient fluid or is it actually vasopressors? Because maybe in this case, I can actually recruit some of that venous volume by just giving vasopressors. And so this is kind of the long backstory here, but how does this relate to the venous congestion assessments? When I have a patient with severe venous congestion, who I'm worried that are less fluid tolerant, that may push me to trial vasopressors earlier with the hope that I can recruit the mean systemic filling pressure and kind of recruit that venous volume, increase forward flow without giving fluids. Because again, fluids are that credit card that I'm going to have to pay off down the road. And that patient already has signs that they're in too much debt, so to speak.
Yeah.